Good evening, everyone. Thanks for joining us for CRI's first Ask the Expert event. My name is Kevin Hudson. I'm the Director of Development and Communications at CRI. Thank you so much for joining us. For over 30 years, Community Research Initiative has been at the forefront in the fight against HIV, providing life-saving services and cutting-edge research so that people with HIV can live longer and healthier lives. Tonight, we're talking about PrEP. PrEP, when taken regularly, is up to 99% effective at preventing new HIV transmissions. It's the greatest tool we have right now to fight HIV. We're excited to hear from our speakers tonight about upcoming ways that we can get PrEP. We're thrilled to be joined by CRI's Director of Research, Dr. Amy Colson, and Kevin Herwig, who is Manager of Biomedical Interventions at CRI. If you have any questions for Dr. Colson or Kevin Herwig, please put them in the chat. We'll have time to answer them at the end of the program. So let's get started. I'd like now to introduce our Research Director, Dr. Amy Colson. She is a graduate of Harvard Radcliffe College, Harvard Medical School, and Harvard School of Public Health. She's been honored for both her clinical and research practices and has presented her research findings at international conferences and in notable peer-reviewed journals. In addition to her work at CRI, Dr. Colson is a physician specializing in HIV and hepatitis C care for Cambridge Health Alliance. Her clinical practice is based at Cambridge Hospital Zinberg Clinic, which houses a multidisciplinary team of medical and mental health professionals who provide care to complex patients, many of whom struggle with mental illness and addiction in addition to HIV. So please welcome Dr. Amy Colson.
Thanks, Kevin. I'm going to be speaking to you about PrEP today using slides. And we'll start by talking about the current options for PrEP and then move into future options, which are really exciting. Next slide. But before we get started about talking about PrEP, I just wanted to acknowledge that it was 40 years ago this week, actually, that the first cases of AIDS were described in the United States. It was a description of 5 men with pneumocystis carinii pneumonia, which we all know now is a rare pneumonia which affects people with suppressed immune systems. The report appeared in the MMWR. Next slide. But of course, we all know that the real beginning of the story is about 100 years ago in Central Africa, when a virus, the SIV or simian immunodeficiency virus, CPZ for chimpanzee, moved from a chimpanzee to a person in Central Africa. And from this patient 0, the virus spread out to account for HIV-1 group infections worldwide. Next slide. And from this sentinel event about 100 years ago, we've had an epidemic that has affected close to 76 million people, killed close to 33 million people. We still have about 38 million people living globally with HIV, and 1.7 million new infections in 2019. Next slide. The status of the epidemic in the United States has been somewhat static over the past couple of years, with about 40,000 new cases each year, 67% of which are attributed to men who have sex with men. Next slide. So keeping in mind that we had 1.7 million new cases of HIV in 2019, we have the tools to stop HIV transmission without a vaccine, which remains elusive. And these include treatment as prevention, which means treating everybody with HIV to the point where their viral load is undetectable and they are not able to transmit the virus, and pre-exposure prophylaxis, which is antiviral medication given to those at high risk of HIV infection in order to provide a pharmacologic barrier to infection. Next slide. So we'll talk briefly about currently available PrEP options, which are oral Truvada and Descovy. And we'll talk about an alternative to daily dosing of Truvada. And then we'll move into the PrEP options, which are on the not too distant horizon, including injectable cabotegravir dosed every 8 weeks, a dapivirine vaginal ring, oral islatravir dosed once per month, a yearly islatravir implant, and subcutaneous lenacapavir dosed every 6 months. Next slide. And this is just to remind you that the PrEP guidelines, which are put out by the CDC and the Department of Health and Human Services, were updated and released in draft form on May 17th. The CDC is currently accepting comments on the draft and expect to finalize it by June 30th. Next slide. So currently available PrEP consists of one pill administered once daily of either Truvada or Descovy. Truvada and Descovy are very similar medications. They both include emtricitabine plus tenofovir prodrug. In Truvada, this drug is tenofovir disoproxil fumarate, and in Descovy, a different version of tenofovir, which is tenofovir elafenamide. The difference between the two tenofovir drugs is that tenofovir elafenamide reaches very high concentrations in target cells and therefore can be administered in smaller doses. Next slide. The evidence base for oral PrEP, so for Truvada and Descovy, the two drugs have been studied in somewhat different populations. Truvada has been studied in men who have sex with men, in transgender women who have sex with men, in heterosexuals with HIV-positive partners, whereas Descovy at this point has only been studied in men who have sex with men and also a small number of transgender women. And this was in one trial, which compared Descovy to Truvada, called the Discover trial. I'd like to point out that there is really minimal research on PrEP for people who inject drugs. There's been one study of tenofovir, and there has been absolutely no research on PrEP in transgender men. Next slide. So as Kevin mentioned in the introduction, PrEP is highly effective if you take it. Both Truvada and Descovy reduce the risk of acquiring HIV through sex by 99%. It is true that there have been a handful of cases of HIV infection among men who have sex with men who really have been verified to be taking their PrEP, but this is really rare. And it's likely due to acquisition of HIV that has pre-existing resistance to emtricitabine or tenofovir. Next slide. So oral PrEP is highly effective if you take it, and the standard of adherence is somewhat different depending on who's taking it. Pharmacokinetic studies have showed that among men who have sex with men, about 4 pills a week provides 96% protection against sexual acquisition of HIV. So there's some real forgiveness in the dosing there. This is in contrast with women who don't achieve as high levels of tenofovir in target tissues, the lower vaginal tract, and therefore an adherence of 6 to 7 doses per week is really required to have such high level protection. Next slide. And then in transgender women, there are some studies that have shown that high doses of feminizing hormones, so estradiol, potentially lower the levels of activated tenofovir in rectal tissue. And therefore, a high level of adherence is probably required and strongly encouraged in transgender women. Next slide. So we have this highly effective tool. There's an estimated 1.2 million people in the United States who have indications for PrEP, meaning that they are at high risk for HIV. And as of June 2020, so about a year ago, it was calculated that only about 19% of people with indications for PrEP are taking it. In Suffolk County, Massachusetts, where CRI is located, we actually have a much higher than average PrEP coverage, with close to 41% of people with indications for PrEP being prescribed PrEP. Next slide. And it's important to realize that the inequities in healthcare extend to PrEP, that the equitable provision of PrEP to the populations at highest risk of HIV is not occurring. So in 2018, 42% of new HIV diagnoses were in the African-American community, and PrEP coverage was 6%, meaning that only 6% of members of the African-American community with indications for PrEP were receiving PrEP. Similarly, in the Hispanic community, 27% of new diagnoses of HIV were in the Hispanic community in 2018, with a PrEP coverage of 10%. And 19% of new diagnoses were in women, with a PrEP coverage of about 7%. Next slide. So what's driving this suboptimal uptake of PrEP? There's a number of factors that have been identified. And I think one of the ones that I see most in my practice is concern about side effects from Truvada and from Descovy. And this concern takes several flavors. One, there's a concern about startup side effects, so nausea and headache. And it is true that during the first month of PrEP with either Truvada or Descovy, there's often some nausea and some headache. It really does tend to get better. There's also been a lot of concern about long-term side effects, the impact of Truvada on kidneys and bones, and some emerging concern about progressive weight gain on PrEP. Next slide. So one of the things that's driven concern about PrEP side effects, and I think impacted the uptake of PrEP, has been misleading ads on social media by personal injury lawyers, which have contributed to a misperception that Truvada is highly toxic to bones and kidneys. This is an ad that one of my patients saw on social media, which he brought to me. He stopped his Truvada and several months later became HIV infected. Next slide. So let's just take a moment and look at the data. So there was a big study that established the efficacy of Truvada for PrEP called the iPrEP study. It compared Truvada to placebo in 2,500 men who have sex with men and transgender women. And it actually showed that kidney toxicity was exceedingly rare. There were only 5 individuals out of 1,200 plus on Truvada who had evidence of, sustained kidney dysfunction. So less than 1% of recipients. And in all these recipients, when Truvada was stopped, the kidney function returned to normal. There's another trial. When we go back a slide, great. So the Discover trial, which I touched on before, compared Truvada to Descovy. This was a very large study. So 5,300 men who have sex with men and transgender women. And this chart shows the median change in the eGFR, which is an estimate of kidney function after 2 years on the study. And what it showed is that there is really no clinically meaningful difference between Truvada and Descovy in terms of impact on kidney function. Next slide. The other concern that's been prominent on social media and among patients about PrEP is that your bones will become thin. Again, the iPrEP study did show that among Truvada recipients, bone mineral density declined a very small amount, about 1% during the first few months of treatment. And then this decline stabilized or reversed. There was no difference in fracture rates between Truvada recipients and placebo recipients in this trial. And again, looking at the Discover trial, which compared Truvada and Descovy, there was no meaningful difference in changes in bone mineral density during the 2 years of that have been analyzed so far. And the absolute the impact on the bones was quite small for both drugs. Next slide. So weight gain. Again, looking at the Discover study, which compared Truvada and Descovy, there was about a half a kilo weight gain during the first 2 years of the study in the Truvada arm, which is less than the average American weight gain. The average American weight gain is about half a kilo a year, and this was half a kilo over 2 years. In the Descovy, in the Descovy arm of the trial, there was about a 1.7 or 3.25 pound weight gain during the first 2 years of the study. So there is a bit of weight gain, a bit more weight gain with Descovy. Next slide. So just to summarize, Truvada and Descovy, they are both really effective at preventing sexually acquired HIV among men who have sex with men. Truvada also has demonstrated high efficacy among heterosexual men and women. Both drugs are very safe. There's a really low risk for bone and kidney toxicity. The one place where Descovy would be preferred to Truvada is in patients who already have moderately impaired kidney function or have bone safety concerns. Descovy may be associated with more weight gain than Truvada. Kevin will get into this more, but generic versions of Truvada are lower in cost than Descovy, which is on patent until 2022. And so I think for the most PrEP users, Truvada is really the preferred option. Next slide. So alternatives to daily PrEP. Taking a pill every day is tough, especially for a preventative indication. And so there has been a lot of research into alternatives to this daily pill. And we'll go through these starting with injectable cabotegravir. Next slide. So cabotegravir is coming soon. On May 4th, ViiV, the company that makes cabotegravir, initiated a rolling submission of a new drug application to the FDA. And on May 17th, in the updated PrEP guidelines, the CDC actually gave cabotegravir a high recommendation, a 1A recommendation for both men and women, conditional on FDA approval. And it's expected that we will have cabotegravir available by later this year, or certainly by early 2022. Cabotegravir is administered as a shot in the buttocks every 2 months. Next slide. There were 2 very large studies that support the safety and the efficacy of cabotegravir PrEP. And they were HPTN 083, which was a study of men who have sex with men and transgender women, 4,500 participants in multiple sites across the globe. HPTN 084 is an ongoing study of cisgender women, 3,200 participants. This study was done mostly in sub-Saharan Africa. Both the studies compared cabotegravir injections to oral Truvada taken every day. The studies were blinded, meaning that patients who were receiving active cabotegravir got a placebo Truvada pill every day, and vice versa. Patients who were receiving Truvada got a sham injection every 2 months, excuse me. Next slide. So what these studies seem to indicate is that cabotegravir has superior efficacy to oral Truvada. You can see that in the study of cisgender men and transgender women, 51 people acquired HIV, 39 in the Truvada arm and 12 in the cabotegravir arm. Similarly, in the study of cisgender women, 40 women acquired HIV during the course of the study. 36 of the acquisitions were in the Truvada arm and 4 were in the cabotegravir arm. Next slide. So, breaking these incident infections down, of the 39 infections in the Truvada arm, it appeared that 37 people who seroconverted were just not taking their Truvada. And the other two who seroconverted appeared to encounter virus with Truvada resistance, which again just points to the fact that adherence to this daily pill is tough, but really critical for efficacy. Of the 12 infections that occurred in the cabotegravir arm, 8 infections occurred during an oral lead-in or after a delayed or missed cabotegravir dose. But there were 4 infections which occurred despite perfect administration on time of the cabotegravir injections and documentation that the levels of cabotegravir in the body were at target to prevent HIV. So these were 4 true breakthrough infections. Next slide. In terms of the safety of cabotegravir, very safe. There is pain at the injection site, and the pain is much more common with the active drug than the placebo saline injection. About 80% of people in the study of cisgender men and transgender women had pretty significant pain. 2% discontinued because of discomfort at the injection site. There was a weight gain of about 1.3 kilograms per year on the cabotegravir arm versus about 0.3 kilograms per year on the Truvada arm. Interestingly, in the study of cisgender women who got cabotegravir, pain seemed to be less significant, and no participants discontinued due to injection site reactions among the women. Next slide. So this is a bit of a confusing slide with a lot of words on it, but what it's meant to communicate is that there were 16 people in the study of men who continued to receive cabotegravir after acquiring HIV. And among these 16, there was a delay in diagnosing the HIV because the standard test that we use, the HIV antibody antigen diagnostic test, was falsely negative. And this delay in diagnosis set up a situation where the person who acquired HIV could develop resistance to the cabotegravir. And this indeed did happen in 5 out of 16 individuals who stayed on cabotegravir PrEP after acquiring HIV. So the message here, I think, is that we're going to need to monitor people really closely who are on cabotegravir PrEP for incident HIV infection, and that this monitoring is likely going to have to take place with a more sensitive test, an HIV viral load test, rather than a standard HIV antibody antigen test. And of course, this is going to be more costly. Next slide. The other thing to keep in mind with cabotegravir is that it stays in the body really long. So this is called the cabotegravir tail. And pharmacokinetic studies have suggested that the median time to cabotegravir becoming undetectable after an injection was 44 weeks for men and up to 67 weeks for women. And at some point during this tail, the levels will fall below what is needed to protect against HIV. And should someone then acquire HIV during this cabotegravir tail, there could be a situation again where the acquired HIV could develop cabotegravir resistance. And so when we have patients on cabotegravir PrEP, should they want to change or stop their cabotegravir PrEP, it's going to be really important to make sure that they're on an alternative form of PrEP if they remain at risk for HIV. Next slide. So just to summarize cabotegravir in practice, what's going to be required is a negative HIV viral load within 1 week prior to initiation. There's going to be an injection into the glutes, followed by a second dose 4 weeks later, and then the doses pick up at a schedule of every 8 weeks. There's going to need to be an HIV viral load assay at every injection visit to look for seroconversion. Unlike Truvada and Descovy, there is no need to monitor kidney function. In terms of the injection site reactions, these can be managed with over-the-counter analgesics for a day or two. And patients need to be made aware of the long tail of gradually declining drug levels when discontinuing cabotegravir to prevent acquisition of HIV that could develop cabotegravir resistance. Next slide. So for people who don't want a gluteal injection every 2 months and who can't see themselves taking a daily pill, in part because sexual activity may be less frequent, there is an option of doing what's called on-demand or event-driven Truvada. And this schedule is 2 tablets, which are taken 2 hours to 24 hours before sex, and then 1 tablet daily while sexually active, and continued for an additional 2 days after sexual activity has stopped. This is, as of now, an off-label use of Truvada. This schedule of dosing has never been studied in the United States, and to my knowledge, the data has not been submitted to the FDA for review and approval of this dosing schedule. Next slide. This dosing schedule, however, has been really well studied in Paris and in the surrounding area in something called the ANRS Prevenir study. This is a multi-center open label study which is ongoing, predominantly among cisgender men who have sex with men. It's enrolled about 3,000 people, and the study subjects have chosen whether they want to be on daily Truvada or do the on-demand 2-1-1 schedule. And interestingly, the cohort has split pretty evenly between the 2 options. Next slide. And what you can see is that the incidence of HIV in both the daily PrEP arm and the on-demand PrEP arm is absolutely identical. Both regimens were also really well tolerated in this study. Most participants stayed on the study, and there was a really high incidence of bacterial sexually transmitted diseases, chlamydia, gonorrhea, syphilis, which showed that condomless sexual activity was really high among these study participants. Next slide. So in this study, there were 6 people who acquired HIV, 3 in the on-demand arm and 3 on the daily arm. And again, same message. It looks like the people who seroconverted were simply not taking the drug. Next slide. So summary of on-demand PrEP. In practice, it's not FDA approved. It's an off-label usage. I do recommend it for patients of mine who have less frequent sex. It's only been studied for Truvada, not Descovy. It's only been studied in cisgender men who have sex with men. And again, probably most appropriate for men who have sex with men, who have sex less than once per week, and also who can anticipate sex by at least 2 hours. Next slide. So now we're moving into a female-controlled PrEP option, which I think is wonderful because, as we all know, women can't always negotiate for condom use. So this is the Depivirine vaginal ring. It's a flexible silicone ring which is impregnated with a drug called Depivirine, and it releases Depivirine into the vagina over the course of 1 month. There's not much Depivirine which is absorbed into the rest of the body, and women can insert and replace this ring themselves. It does not need to be done by a medical provider. Next slide. The HOPE study looked at the effectiveness of the Depivirine vaginal ring, and it showed that the ring reduced the HIV incidence by about 39%. So this is not as effective as the other interventions that we've discussed. Next slide. But it has been approved by the European medicines agencies and also recommended by the WHO with the caveat that it should be used as part of a complementary prevention approach in addition to other safer sex practices. I think this is a nod to the sort of moderate efficacy of this intervention. And this is being reviewed by the FDA now, with the decision expected by the end of 2021 in the United States. Next slide. Further away is the islatravir subdermal implant. So this is a matchstick size implant with the drug islatravir impregnated in it, which can be inserted into the upper arm. For those of you who are familiar with the Nexplanon contraceptive technology, this is identical technology. The insertion can occur by, in a regular office. You don't need an operating room, by someone with not too much training. Next slide. This has only been looked at in phase 1 trials so far. A phase 1 trial was recently presented at Virtual CROI 2021. And what it showed is that the islatravir implant that's moving forward should really produce protective drug levels for about 12 months. It was well tolerated. So the 36 participants who received the implant did have some mild discomfort at the site of the implant, redness, tenderness, pain, but that it was really mild. And phase 2 trials are planned. Next slide. Islatravir, this same drug, is also being looked at as a monthly oral PrEP pill. So a pill administered once a month to provide protection for the whole month. And a pair of phase 3 trials have been launched. So they're now underway to test this approach of a monthly oral pill. One of the trials is in men who have sex with men and transgender women, and one is among cisgender women and adolescent girls. Next slide. And the final drug that's in development that's exciting for PrEP is a drug called lenacapavir. And this is being looked at as a subcutaneous shot. So much like insulin, just popped right underneath the skin of the belly to be administered every 6 months. There have been animal studies which support this approach, and trials will be starting soon in adolescent girls and women in sub-Saharan Africa, as well as cisgender men, transgender women, and transgender men who have sex with men in the United States and South Africa. Next slide. So, lots and lots of exciting options for PrEP coming down the pike, especially cabotegravir, which will be quite soon. Next slide. But the challenge is really now implementation. So how do we make these menu of options acceptable, accessible, and affordable? Next slide. And so, in terms of accessible, Massachusetts is one of a handful of states which actually has a PrEP drug assistance program. The others are California, Colorado, DC, Illinois, New York, Ohio, and Washington State. And I will turn it over to Kevin Herwig to talk a bit more about this. And again, any questions I can take at the end.
Thank you so much, Amy. So we're going to switch over to Kevin Herwig. Lizzie, you can stop sharing the slides. Kevin Herwig is hold on here. Kevin Herwig is manager of HIV biomedical intervention programs, including PrEP, drug assistance program, and MPEP programs at CRI, originally from the Bahamas. He trained as a linguist and has lived and worked around the world. Please welcome Kevin Herwig.
Hello, everyone. Forgive me, I'm on my iPad, so you will sometimes see my fingers as I struggle with the technology, but you can hear me and see me, right? Thanks everyone, and thanks Dr. Colson. There were so many fascinating things in your section. I run PrEP and the NPEP program. And so in our 31-year history at CRI of running the state's HDAP program for people living with HIV, alongside that, we've also since 1997, so basically for nearly a quarter century, had been able to assist some people who are at risk for HIV with prescription drug costs, namely our NPEP program, which was founded in 1997, and our PrEP program since 2017. So I'm just going to talk with you a bit about what we've seen over the past 5 years, and it's really great. I see we have a more intimate group, so I'll try to be brief so that we can allow, hopefully, for energetic discussion and questions. So just to start out with some remarks about PrEP, we've seen that PrEP can be a really transformational and, in fact, revolutionary intervention for many populations that are at risk for HIV. It is amazing to have two safe and effective drugs that provide over 99% protection and many more exciting PrEP drugs in the pipeline. It's also great that PrEP use has really, over the past 9 years, started to become more normalized, really maybe even especially for gay men, especially urban gay men who know how to get PrEP and know where to get it from providers that they're comfortable with. But after 9 years of PrEP being available, uptake is really, as we saw so dramatically in Dr. Colson's slides, in many populations, really not anywhere near as close as to where it should be. So many people who are at risk for HIV have never been on PrEP, are not on it, in many cases have never even heard of it, or ever had a provider speak to them about PrEP, and no idea where to get it. And just to review, on one of Dr. Colson's slides, I believe the numbers were from June 2020, only 1 in 5 people who have an indication for PrEP around the country is on it right now. And in Boston, the figures are a bit better. Suffolk County, 40%. Again, that's from mid-2020. So clearly, when I saw the 40% figure, I actually thought, oh, wow, that's great. But when you think about it, that's still quite low, with 60% of people still, not on PrEP. And a very important part of the problem is basically paying for it. So PrEP has been a pretty expensive drug so far, and we're just starting to see the beginnings of that changing with the introduction of a generic version of Truvada. The basic problem is that health insurance coverage in the United States is incredibly fragmented. It's in many cases different from state to state. It's really complicated and also ever changing. And even for insured people, there are many people who can't afford their out-of-pocket costs, which is why we need these drug assistance programs. I'm not going to get into the nitty-gritty of eligibility. I'll just sort of give an overview of what we've been able to do in PrEP and NPEP with basically we're able to offer very fast approvals. We approve coverage for post-exposure prophylaxis, which is always urgent and time sensitive, within minutes, maximally hours. And for PrEP, we nearly always approve coverage on the same day. And again, it's very easy to call us to get expedited to coverage. And many of the sites that use us very frequently, it's common for people to have PrEP coverage in place before they even get to the pharmacy, the on-site pharmacy. It's also really important that we've been able to be quite flexible. As a state-funded program, we can offer pretty flexible policies, especially compared to federally funded programs like ADAP, which comes with all kinds of strings that are attached to Ryan White program requirements. So we can offer pretty seamless coverage of PrEP through people who are going through insurance coverage transition. So from uninsured to insured, and changes in insurance coverage, which are, have always been common and have been even more common during the COVID pandemic. We're also able to give coverage for people who have confidentiality issues about using insurance coverage that they have through a spouse or a parent or a guardian. And there are a lot of things that we're able to cover on a case-by-case basis, especially for people who are very elevated risk for HIV. It's also important that we always have been able to cover PrEP. I think one of the things that it teaches us is, it teaches us how to solve problems quickly. We know how to scramble to get someone PrEP, make sure that people who need PrEP get the drugs they need at a pharmacy that have them in stock. I think one of the very key attributes of our programs here in Massachusetts is benefits navigation. And actually, I would say that of the states with PrEP and PEP drug assistance, we're the best at that by far. Through our bridge team, we have very energetic efforts to navigate people's health insurance coverage, enroll in coverage, triage their health insurance problems, both for people who are living with HIV and people on PrEP. There's, in longer trainings about PrEP and MPEP, there's, sometimes we have to get into the nitty-gritty of health insurance coverage, and, people's eyes really glaze over. The details are incredibly tedious if you don't have an interest in it. And there's no, you can really lose an audience quickly when you start to talk about Medicare Part B or partial health safety net dental coverage and all of that. The point is, and this is something that we have seen, there are cases where a young person, goes to the pharmacy and can't pick up their PrEP because of a change in their coverage. And then we have seen people seroconvert within weeks. And that is what we're here to prevent. In Massachusetts, particularly because the health insurance picture is fairly good, it means it's more complicated. We have more options. Some of the options don't exist in other states, but this makes it harder to understand and to navigate. And it's really important that we sit here in Massachusetts and we know the details of the coverage. And sometimes we've seen efforts at national level tools to help people with health insurance. They tend to be really misleading in a state like Massachusetts. It's also important that we're basically a place that people can call. We always say, please don't hesitate to call about anyone in the state who's having trouble accessing PrEP or PEP, and people do call. They're individuals who are in need of PrEP and PEP. In many cases, they're not getting PrEP care anywhere. And we get calls from providers who are not familiar with our programs. There's an aspect where our friends who show up at our events are often from some of the very best places that are offering PrEP and PEP. And it's important to remember that so many people getting PrEP are going, to non-HIV specialized providers, in many cases, quite random. And so especially in that setting, people do need quite a lot of help. We also we have an energetic program of doing trainings around the state. During the COVID pandemic, we've been able to do that virtually. And really that helps keep people, abreast of the constantly evolving picture of both PrEP and PEP, and also of what we're able to do. Just to give you a very brief sense of numbers, in a typical month, we enroll, around 30 PrEP app clients, and we serve maybe 1 to a dozen people who need NPEP coverage. So over the years, we've enrolled in PrEP app. I think we're getting up to about 1,200 Massachusetts residents. Just to give you a very brief overview of demographic characteristics, in terms of race and ethnicity, we're fairly in line with the HIV epidemic. Our PrEP app enrollees have been about a quarter African-American, about 40% Latino, basically 86% have been MSM. That's been quite a stable number throughout the history of PrEP app. So about 91% male, only 6% female, and 3% trans or gender diverse. And those numbers have been quite stable. It's important to remember that PrEP app clients are pretty young. About over 70% of our clients are in their 20s or 30s, and that really makes a difference. Especially people in their 20s are more likely to be shifting jobs, have shifting income, be housing unstable, and frankly, be uninsured. And as we know, many, especially young men, often very poorly connected with the healthcare system. And it's important to keep in mind that many PrEP patients are really quite healthy, and perhaps only, especially the younger they are, interact with the healthcare system really mostly to get PrEP. So just to speak briefly about, Amy mentioned that there are about, I think about 8-9 states that have PrEP drug assistance programs. Just to give you a sense of how they differ with us, a few states, we have an income limit on the PrEP side. There are 2 states that have opted not to have a limit, and that really offers some advantages and some disadvantages. Formularies are really quite different. One state, Washington, limits its coverage of oral PrEP to Truvada alone. Some states have added STI treatment drugs and even vaccines to their formularies, which is very interesting. And some states are able to cover a fairly generous assortment of labs, both directly PrEP associated and also, other, for instance, hepatitis labs that are frequently ordered at the same time of prescribing PrEP. So one thing that we talk about all the time is what we always call it the changing landscape of PrEP. And it's really, there's no better way to describe it. It's, we often say to people who are, doing a PrEP training, really we should schedule another one in a year because things are changing. So for many years, the PrEP scene was really very simple. In 2012, Truvada's PrEP was introduced, and we had that alone for 7 years. And that was quite simple, especially because, it couldn't become that complicated with different payers having too many different policies with only one drug. So Descovy was introduced in October 2019, and so it is for a more limited population than Truvada. Then the generic version of Truvada came along, and that really changed the payment environment in Massachusetts because the manufacturer copay card was no longer legal in Massachusetts. And now we have a feature of the ACA that basically requires that many, not all, private insurance plans should institute $0 copays for at least one oral PrEP drug. And we have seen, so it's great to have these options. It's really great to have zero copays, but there is a downside. Basically, accessing PrEP has become increasingly complex, especially through private insurance. It can be very hard to find information on private insurance formularies about which drug is covered at zero copay, and also utilization management on other, and prior authorization requirements have become much stricter. So as it's great that non-oral PrEP is coming, but we can expect that as payer policies evolve, there will be a much more confusing scene than when we had one drug. So I just want to say a few words about key populations. So in general, in Massachusetts, our uptake has been pretty excellent compared with the rest of the country. I think, depending on how you look at it, there tend to be 1, 2, maybe 3 states that are better than us. It's really great, again, that our insurance coverage options are quite good for everyone. And it also really helps having a PrEP drug assistance program really helps in those states which have one. So we had about 8,000 people on PrEP in 2019, which is outstanding. I think that, was, like nearly a 57% improvement on the year before. So basically we have, in 2019, we had about nearly 14 people on PrEP for every HIV diagnosis. That's pretty good. But it's super important to make sure that all key populations who might benefit from PrEP are they need to be able to access information about PrEP that's geared to their specific concerns. And they should also be able to see themselves in outreach materials like ads and so on. And of course, this isn't a zero-sum matter at all. We absolutely need materials for gay men, but we also need materials for women, for trans women, and for trans men, and for sex workers, people who inject drugs, and et cetera, et cetera. And just to give you an example, for instance, in material oriented towards trans people, you can address the issues about hormone treatment that Dr. Coulson brought up. So I don't really have enough time really to go through all of the possible key populations, but I do want to make some remarks. I'm going to start out with cisgender women. So women are 6% of PrEP users, and that number has actually been quite stable. That's true for Massachusetts, and that's also true for PrEP. It's important to remember that women are about a third of all the people living with HIV in Massachusetts are women, and they're also nearly a third of recent diagnoses. So to look at it in another way, in Massachusetts, we have nearly 18 men on PrEP for every man who gets diagnosed with HIV. When you look at women, we have only under three women on PrEP for every woman who's diagnosed with HIV. So this is a very steep and very remarkable disparity. And of course, the women affected are disproportionately women of color, especially Black women. So it will be important, there's so much work to be done, especially in populations where sexual networks have a higher prevalence of HIV. I look forward to a future in which we get calls from OBGYNs and I don't know, mental health providers, or where we have more family planning clinics than we currently see. We see some, but we don't see many. So there's lots of work to do. Also, with men who have sex with men, which really, are both in Massachusetts and around the country, a very large proportion of the people who are diagnosed with HIV. PrEP uptake has been quite successful among men who have sex with men, but there's so much work still to do. If you look at Black or Latino MSM, lifetime HIV risk remains very, very high. 1 in 2 for Black men who have sex with men, and 1 in 4 for Latino men who have sex with men. It will be, it's very important to reach non-native born people. And it's important to reach people in the substance use context. Just to mention very quickly a few, other populations that we hope to do more work with. Sex workers, super important, absolutely key, and very hard to reach. Mostly not on PrEP, mostly not insured. People who are at risk for intimate partner violence, that always correlates with increased HIV risk, and also people who have just been released from incarceration. So that's among the things that we are looking forward to improve. So just 1 second, I'm looking at time. I'll just say one other thing. One of our key messages is don't forget about PEP. Post-exposure prophylaxis is so important, especially when uptake of PrEP has been as low as it is. It's really when people are at high risk for HIV, there are many people who are in the PEP window of 72 hours after a potential exposure, and then it's very important to consider them for PEP and potentially they can continue on to PrEP. Another point about PrEP that has been very promising during the pandemic is that PEP and telehealth, we've been seeing more of that, and that's really great. So when someone presents for is eligible for PEP, say at a community-based agency, we've been able to connect them through telehealth at a clinical site that's somewhere completely different. Very quickly. So we hope to see more of that. I think I'm actually going to, to stop right there and then leave some time for questions and discussion.
Thank you so much, Kevin. We do have time for a couple of questions. We have a couple in the chat. Question for Dr. Coulson. With the tail being so long for cabotegravir, is there a possibility of drug interactions if changing to a different PrEP option?
Yeah, it's a great question. In terms of drug interactions for cabotegravir, so cabotegravir is hepatically metabolized, not through the common CYP3A4 system, but by a UGT1A1 and 1A9 system. So there are not a lot of drug interactions. The major drug interactions for cabotegravir are with TB drugs, actually, the rifamycins, and also with some older anticonvulsants like phenobarbital, carbamazepine, and oxcarbazine. So there probably will not be concerning drug interactions if someone were, for instance, to switch from cabotegravir to Truvada, cabotegravir to islatravir, coming down the pike, some of the other options. The other interesting pharmacokinetic aspect of cabotegravir is that it is like very highly protein bound, meaning that it doesn't get dialyzed. So for people who are on dialysis, it might also be, a good option. I'm not sure if that'll show up in the label or not, because I don't think it's been studied, but it could be an off-label application.
That's fascinating. Another question, what are complementary HIV PrEP options recommended for women in addition to the dapivirine ring if women cannot navigate condom use in her partners?
Yeah, so I think, I think probably oral PrEP, now it would be Truvada or Descovy. I mean, the dapivirine ring, you don't get systemic absorption, so it works mostly in the vagina. So for women who are having anal sex, it's going to provide no protection, and that may be some of the diminished effectiveness that was shown in the studies. So I think a more systemic option like oral Truvada or Descovy would be a good option. And of course, some of the other agents coming down the pike, which are being well studied in women, which is fantastic. I mean, all the studies are, of the newer agents are being looked at for women. So hopefully we'll see more options for women.
Why isn't PrEP talked about the same way as birth control is for women?
Yeah, I think for women, there is a lot of stigma. I think that women don't want to be, seen as someone who needs PrEP, honestly. So I think there is a lot of stigma. And I also think that for many women, there is an underestimation, both by women and by their providers, of what their risk is. So I think there's not a recognition of the risk. And, women who have sexually transmitted diseases, chlamydia, gonorrhea, syphilis, should all be looked at for PrEP.
Question from Jeffrey Schaefer. Cabenuva HIV viral load testing concerns me, as I'm sure it does everyone. Conversations with DPH about testing options?
So meaning that the monitoring of people on cabotegravir for seroconversion would be a viral load test? Is that what's concerning? Yeah,
Yes.
Yeah, it's concerning. I mean, I think it's concerning from a cost perspective, dramatically more costly. But that's not the only thing that's going to be more costly about cabotegravir PrEP. Cabotegravir PrEP itself is going to, just the drug itself, is going to be much more costly as well, probably. I mean, it's not FDA approved, so we don't have the price, but I expect the drug itself will be very costly. And then there's, the third fee, which is the administration fee. By a healthcare provider. This is a deep gluteal injection that cannot be self-administered. So I think overall the costs associated with cabotegravir are going to be, high. But because theoretically the adherence may be better, it saves costs on seroconversion and caring for someone for a lifetime with HIV. So cost effectiveness studies have looked at all those different parameters.
Dr. Colson, can you talk a little bit about the new CDC guidelines? I would imagine that they would possibly help with that, with educating our peers and letting the general public know more about PrEP.
Yeah, I think, the new guidelines, interestingly, there used to be sort of complicated guidelines on who we should consider for PrEP, the social context of their partners and, how many acts of condomless sex in the past 6 months. And the new guidelines really simplify things and say that every adolescent and adult who is sexually active should be given information about PrEP. Now, the discussion obviously goes beyond that, where you look at social context. Are there multiple partners with unknown HIV status? But the initial message is that every adolescent and adult who's sexually active should be, given some information about PrEP. So to me, that was the most striking new thing. And then the other striking new thing is that they gave a 1A recommendation to cabotegravir, which is not FDA approved yet. So that's pretty interesting.
Yeah. We are just about out of time. If does anyone have any last questions? If not, we'll go ahead and wrap it up.
Great.
Great. Thank you so much, everyone. This will be recorded. We'll have it up on our YouTube channel in the next couple of weeks. Thank you so much for attending. If you're interested in finding out more about our programs and how you can get more involved with CRI, you can visit us at crine.org, or you can email me at khudson@crine.org. I want to thank our wonderful presenters, Dr. Amy Colson and Kevin Herwig, and thank you all for attending. And hopefully we'll have another one of these again soon.